Welcome to the Death Happens podcast, an insider's guide to dying. We're your insiders. I'm hospice nurse Penny.
And I'm Halley, Hospice Social Worker.
We have a great episode for you today. We are welcoming Dr. Sammy Winemaker, a palliative care doctor in Canada, and also one of the authors of Hope for the Best, Plan for the Rest, which is really one of my favorite books right now. I actually have just ordered my third one because I keep giving them away. I'll meet somebody who's going through a situation with someone with a terminal or life-limiting condition, and I'm like, you've got to read this book. It is just amazing. So I'm so excited to talk to her today.
Me too. Well, before we get to her, let's chat a little bit about the evolution of talking about death and dying and how that's culturally changed, especially over the last few years.
Yeah, it really has, especially since COVID. So I really have noticed when COVID came, I say we tucked death and dying away in the hospitals. It used to be in the home, grandma, grandpa, they used to die in the home with the family. It was very normalized. They kept the body in the house for the wakes. And then, with the advancement of medical technology, people lived longer, but then they'd get to a point where when they're sick and dying, they need to be in the hospital to be able to live longer. And then they were dying in the hospital. So we tucked it away. We tucked death away in the hospital.
It's funny. I was just watching Tombstone the other day, and they, this is the 1880s.
Yeah.
And they were showing the procession with the funerals and the people displayed, the coffins just out in the street. And that wasn't that long ago. And then we went to, like you're talking about this, into the hospital, tuck it away. Don't look at it. Don't talk about it.
Right. Yeah. Until COVID.
Yeah.
I mean, and then everybody's like, it's in our face. People are dying every day.
I think it probably started a little bit before COVID, as far as we're starting that transition with hospice been around for, 40 years. And so that's baby steps started the transition of talking about it. But I think you're right. COVID really smacked us in the face with it, on top of social media coming at the same time, and TikTok specifically.
Right. And I mean, so the implementation of the Medicare hospice benefit happened in 1982, right? Something
in the
around
US.
That. In the US, yeah. So it did start to resurface again. But it wasn't really public knowledge. You really only knew about it more if you were involved in it in some way. And even I remember as a teenager, I was probably 17 years old, 1980 something, 1980. No, 1980. I was like 17 in 1980. And my mom told me that she knew somebody that was volunteering for hospice. And I didn't know what that meant. What's hospice?
Yeah.
What's that? I had no idea. And my mom couldn't even really describe it to me either. Right. It's about people dying. I don't know. That's, that's what it was. So it was like people, knew about it if they were really involved in it. But other than that, it wasn't really out there that much. But it was COVID that really kind of started to bring the topic of death and dying more to the forefront.
For sure.
It's on the news, man. We're seeing refrigerator trucks parked outside of hospitals, packed with people who've died from COVID. We're just hearing a lot more about it. And also, the technology advanced too, where social media became this thing that is easily attainable and consumable.
Yeah.
It's easier to. Facebook's been around for a long time, but it wasn't the little videos that you can watch and go, oh, there's a 1-minute video about, people dying in the hospital.
Even Instagram didn't quite have the same zhuzh, if you will.
No. Yeah. The reels weren't around yet. So,
but then TikTok and COVID brought all of us to you and you to all of us, Miss OG.
Yeah, I guess you could say. But yeah, and I mean, it's fantastic. I really feel like I can see through my TikTok and my Instagram and my YouTube and my Facebook how many people
Change yourself. You're doing a lot out there.
How many people are really wanting to know more about death and dying?
Mm-hmm. I wonder how much of that is autonomy based. Like, the more you know, the more you can plan, the more you can have control over it. And we can't control that we're going to die, but we can have control over how we're going to live before that.
But I think a lot of it is autonomy based, and also because I and the other social media hospice people like you also are talking to people about things that they probably haven't thought about. Like, and on this, like in the almost simplest ways, like denying somebody alcoholic beverage when they're dying, or pain medication if they're uncomfortable. And, and I make these videos about people, like I recently did one about family members not wanting, and it's like literally less than 15 seconds long. It's just the words on the screen and I'm lip syncing or something like that. And it's about family member doesn't want a person to have morphine because they're afraid they'll get addicted. And how many people in my comment section are like, what? That's crazy. And they probably never have thought about that before.
Right. Exactly.
So they do have like this idea, well, that's not what I want, so how much more do I need to know about this just so that I can,
And that is why I am so thrilled to talk to Sammy today, because her book is exactly what we've been talking about, but further upstream, which is even better.
Yes. Yeah. Yeah. I am very excited to talk to her today. And I think it's going to be a wonderful episode. Very
I agree. Well, let's do it.
Let's do it.
Welcome, Dr. Sammy. We're so happy to finally have you on.
Thank you so much for having me. I'm so excited.
Oh, it's absolutely our honor. We are super excited to talk more about your book, your podcast, all the things. Tell us about yourself.
Okay, well, it all started in 1970 when I was born. And now we'll skip forward. I've been in practice as a palliative care physician for about 20 years, and I work in people's homes. So I feel very privileged to work in people's homes and feel like I have developed a whole different skill set that my colleagues will never develop because they haven't trained in this amazing care setting called the community and in people's homes. So that's what I do. I'm part of an outreach team, and I go into houses every day caring for people at the end of their illness. And
I'm sure our listeners are hearing that little bit of an accent. You're up in Canada, yes?
Oh, did you hear an accent? Did I say out and about?
Oh, you have an accent. You have an accent.
Really?
Oh, yeah.
Okay.
Oh, yeah.
Just the about.
Oh,
yeah. About.
Or if I say sorry, I think that's the other.
Yes.
Yeah.
Sorry. Yes. Yeah. So to clarify, because in Canada, palliative care is really what we call hospice.
Yeah. It's all mushed together in Canada. We don't separate them. And when we refer to hospice,
which I love.
When we refer to hospice in Canada, it is more a bricks and mortar place where people can go to die in the last 3 months of life. And they also have, day programs and some outreach programs, but palliative care, encompasses hospice. It's all mushed.
We need to learn from Canada.
Yes, we do.
The irony is people think that sometimes that's what they think hospice is down in America.
Mm-hmm.
Is a place.
Yeah. And most of us do not have access to hospice care centers like Penny used to work in.
Mm-hmm. Mm-hmm. Yeah. Well, anyway, so that's what I do. And amongst other things that I've gotten myself involved in the last little while, which maybe we'll talk about.
Yes.
Yeah.
We're jumping right in because I've been all over this book. So your book, Hope for the Best, Plan for the Rest. I think this is Penny and I's mantra.
Mhm.
And absolutely, you guys, you and, if I'm saying this correctly, Dr. Cien Xiao.
You're perfect. I can't believe
I've
it.
been practicing.
Wow. Perfect.
So you and he have been working on this also it sounds kind of in conjunction with your podcast.
Yeah.
Because I did cheat a little bit and listen to the first couple episodes, which
Mhm.
basically encompass the book chapters, which I thought was a great companion to
Mhm.
the book. I love them both. So can you tell us a little bit about how you two came together?
Before you do, I want to say something about that title. I really like the title because hope for the best, plan for the rest sounds so much better than hope for the best, plan for the worst.
Yeah.
Because
Yeah.
right off the bat, when you say that, the worst, it's like
Yeah.
it's putting this negative, connotation to death and dying. And so
Yeah.
I love it's catchy, and I also love the fact that it doesn't like further stigmatize
Yeah.
end of life care. So
Yeah.
Yeah.
just wanted
Love
to
that.
say that.
Great point.
And there was method to our madness too, because we wanted this information to be offered to people as early as possible in their illness journey. And so what we couldn't do is try to sell them something that was scary, because there's no readiness for that right at the beginning, right? So we wanted the book to
Right.
look pleasing and approachable, and the title had to be full of hope. And we needed people to buy it. If I had written something that was, like I said to my sister one day, I'm going to write a book, What to Expect When You're Dying, just like What to Expect When You're Expecting, that book that pregnant women
Yeah.
read.
Yeah.
The worry was that no one would pick it up early in their illness, right? So hope for the best, plan for the rest is something we thought people wouldn't feel uncomfortable giving the book to people when they don't know what else to do when someone's diagnosed. So it's positioned early. I think that's the difference between this book and maybe some other books. But how did we get together, Cien and I? Well,
before you even say that, I mean, now that you're saying it, as I'm hearing you say it's truly transformational as this is coming out. We were just talking before you were on about how talking about death, normalizing death, the culture shift between the decades and the centuries even, and how it's starting to come back into favor in the world at large, if you will. But it's not normalized quite yet. And this book, like you were saying, I think in your podcast and even in the book, that if you're just teaching physicians, it's going to take too long to get to the public. So I love your focus upstream.
Yeah. Okay. Well, that's a good segue into how Cien and I got so frustrated in our careers. Like both of us wanted to just pack it in because we had spent like very, very many years trying to change the culture of healthcare from, behind the curtains. And that's all very important, but not moving fast enough. So we just got fed up, honestly. He did not want to do more research in the same, and I didn't want to see the same stories over and over again. So we decided to do something, I think that was brave at the time, and, leapfrog over healthcare providers and just go straight to the public. And, when you're a doctor, you, of course, belong to a college, just like nurses belong to a college. And, we're all very mindful of the institutions and the leadership roles that we have. And that stuff can be very silencing. And I was naive enough not to look too deeply into it when we decided to go public facing. And I'm grateful that I didn't, because had I probably read up on what one is supposed to and not supposed to do in this profession, I probably would have been intimidated. But anyway, yeah, so we decided to go, straight to the public, like many others have had, including you guys. I mean, but for me, it was very new, and same with Cien. And we had a huge learning curve, how to take our skill set and offer it in a different vibe to, at a different entry point in the illness journey with a language that was going to be acceptable to people. And and so that's what we did. And we're still learning.
We were just talking with another interviewee Cody and talking about the way that you frame hope and how you reframe it as the journey goes along, that there's never a time when you don't have hope. It's just what you hope for.
Mhm.
Yeah, I don't think I made that
I
up, but people like it. But yeah, no, it's true. I guess I like to think of the difference between a wish and a hope, right? And a wish is something that can be anything and it doesn't have to be realistic. Just like I wish, I was a billionaire and I wish, no one was fighting in this world right now. But a hope has to be more grounded in reality. And the good news is that we can still have hope no matter what stage we're at of an illness journey, right? It just has to change its color, like a rainbow, right? And we can only do that naturally if we have the scaffolding of reality that helps our hope shift from hope that they got the wrong person with this diagnosis, fast forward down the road to hope that I have reconciliation with my family before I die, or hope that, I'm going to have little symptom burden, hope that my family lives on and takes care of each other. I mean, hope is hope is hope. It can stay high,
Mhm.
but it can't be mismatched to where you're at in your illness. That's when we get in trouble. If you're still hoping for a cure and you're bedridden at the end of an illness, we've got some explaining to do.
Yes. Yeah,
So,
definitely.
I feel that's so hard. I can't believe how many people come to hospice, and I'm sure you've had this happen, where you're doing your intake form and nobody's even told them they have 6 months or less.
Mhm.
Like
I
they
had
haven't had any conversation before.
That has happened. And speaking of that,
mhm,
Sammy, what is the requirement for palliative care / hospice in Canada with respect
mhm.
to diagnosis and prognosis?
Yeah, I mean, don't you wish that I could just give you a simple answer to all these things, but it's not so simple. So, I mean, there are criteria for services that are different than the criteria for receiving the care, right? So if we're talking about a philosophy of palliative care, a palliative approach, really anyone who's facing a life-limiting illness deserves a palliative approach peppered into their illness journey from the time of diagnosis. And that should be
Right.
delivered by any doctor and any nurse because we've trained them properly and they just do it as the natural part of their skill set. Now, to qualify for a palliative care team or doctor or nurse in the hospital or any other care setting, there really isn't any criteria. What happens though is that we tend to be the transfer of care team that people pass the baton to very late in the illness, and we're overly synonymous with end of life care in Canada, even though we've tried to market ourselves as a helpful consult service at any point along the illness journey. We are still living in an old-fashioned healthcare system here where the baton is passed and it keeps getting passed until they pass it to the cleanup committee, the palliative care specialty teams, which, helps to stitch a person back together to feel like a whole person again right before they die, when they've been reduced to an organ, a diagnosis, a room number, dismembered in many ways. And, once we catch them too late, we try to put them back together and then off they go. And so it's a very problematic, we have a problematic definition of palliative care and people's understanding of palliative care. It's usually over synonymous with cancer, over synonymous with only elderly people, over synonymous with end of life care, over synonymous with hospital settings only. And so I think we probably struggle the same type of problems, across our borders.
Yeah, I mean, everything you just said, it's like, oh yeah, that sounds like hospice.
Yeah.
It's exactly, so here we are thinking, yay, you guys have the right model. You've got palliative and hospice. It's all one thing.
No.
And for us, it's the same thing. People are referred too late.
Mm-hmm.
It's the last ditch effort
Yeah.
to try to do something with them before their death. And it's almost, I mean, it's often too late. So that's so interesting. And so do they, in the US, they have to stop curative treatment in order to be on hospice. So in order for the palliative team to take over, which is what I kind of hear as the hospice part of palliative care for you guys, can they still seek treatment up until their time of death? Or is there a point where in order to qualify for your services, they have to stop that treatment like they do in the US?
So to have a palliative care service involved in the hospital or at home, I'm part of an outreach program. That is not one of the criteria. And you don't have to be an allow natural death or DNR. You can receive palliative care alongside, other disease modifying treatments. To go into a hospice in the last 3 months of life, you must be an allow natural death or a do not resuscitate. But if someone is in one of our hospices and they require radiation for pain management, that's no problem. Or they require a transfusion because it's helped with their quality of life, they can still go to the hospital and get one. Or if they need, a venting peg tube or, BiPAP for comfort, they can still have those types of treatments. Even we've had people, with a feeding tube or come in with TPN. When the goals of care are, though, that they understand there'll be a time where these things will be discontinued. But we try very hard to send a message that it's not, you have to give up this and roll over and die and not receive any other treatments. These things can coincide together. And I think that is the right way to go. I think the reason why it's separated in the States is probably because of funding. It's not philosophy, it's funding.
Well, yeah, that's true. We do also allow certain treatment, like you're saying, radiation to decrease tumor bulk.
Yeah.
Tube feeding. We don't typically do TPN, but that type of thing can be done as long as that, like you say, it's what are the goals of care? It's not to prolong life, it's to prolong comfort, prevent suffering. So we can do those things in hospice. One thing I really, really wish we had that you have there is the hospice care center for people, because that is a huge area in the US that's it's lacking, and caregivers, the burden of caregiving for our dying people is on their family.
Yeah.
And it's so hard for them. So that's
broken on every level.
Well, can I be honest with you? Is that okay? I'm probably going to get myself in trouble, which won't be new, but so we have these amazing, stunning, beautiful bricks and mortar hospices. Okay. And there's probably not every community has one, but those that do usually have a 6 to 10 bed unit, let's just say, usually tucked in some beautiful residential area. And the rooms are stunning. It's like being in a hotel. It's usually nicer than any of our homes, and they get beautiful care. But I will tell you that most of the people that land in our hospices are people with cancer, that it is very inequitable when it comes to identifying other non-cancer diagnoses and when they're in their last 3 months of life. So it becomes inequitable. And then the other thing is, there is so much money that goes into those 10-bed hospices for Cadillac care. And that money could probably be used for respite in people's homes. More people could get a Ford model car in their home instead of 10 people getting a Cadillac in a hospice. I'm telling you, like, I find it disconcerting that home care is so lacking, but then we have a 10-bed hospice that is like for Hollywood movie stars. The difference is so unbelievable. And if we just gave people in the home some respite blocks, like, a personal support worker or volunteer or nursing hours to offload the family for a couple of hours, a couple times a week, that might make the difference between someone being able to stay home or not. So I think that hospices make communities feel secure. They make politicians with the ribbon cutting feel wonderful, and donators love sending money to the hospice, but they do not meet the needs of a community.
You're speaking my language.
Yeah, and it's kind of sounds like our hospice care centers here too, in a way. And I can see where it would be more challenging to have that 3-month prognosis if you're talking about a non-cancer diagnosis, because then we're looking at COPD, dementia, ALS, cardiac disease, these things that are so much more challenging to prognosticate. You can't, it's harder to get into that 3-month window. It's hard to get into the 6-month window, for hospice here. But getting into a 3-month is even more challenging. And so I guess, there are some things that we have that are probably maybe a little better, like the respite benefit that we do have, but then it's not in-home respite. It's trying to find a nursing home that you can put them in.
Right.
And then you are taking them out of their home to do this.
Yeah.
And so, yeah.
That presents a whole other list of problems, trying to pull someone out of their home.
Yeah.
Even if it's for a real needed respite break.
Yeah.
Yeah. Well, even just finding a bed.
Yeah, exactly.
In a nursing home can be hard.
It's near impossible here. We still have such a broken system. And this is why we are trying to, with our work, prepare people to become patients and prepare families to become caregivers and managers of their illness. Because if we can give them these skills and information and the reality of it all, what this is going to look like right from the get-go, they may have a fighting chance not to find themselves further along in the illness feeling very overwhelmed and burnt out. Proactive care is really the only way to go, right? Instead of being reactive to everything.
Yes.
And none of this is new. Like we have the benefit of seeing so many patterns, right? Like pattern recognition is our best friend. No one should feel like, no one's ever done this before. People have done these things before. And so we need to share with people, this is how you have a better in control illness journey. We may not be able to change the illness itself. And, there's specialists to help with that, but we can improve your illness experience. And, that's worthwhile.
Well, and teaching people to be their own advocates.
Yeah.
And I love you. You say if that person is not ready to have the conversation, I love you so much. That you're talking to other people in your group, right? Like one of you should be willing to have that conversation. So when you're ready, you know what's coming.
Yeah. Just like if one person can have their eyes wide open, we're good. Let's be realistic here. It's just like, realistic with our hospices. Like we're giving 10 people Rolls Royce care is not going to be the answer when there are thousands of people in the middle and at the end of their illness at people's homes. So, it's a little bit for everyone is better than all of it for one person, right?
Yes.
So
what brought you to in-home palliative care versus hospital or any other model you have up there?
Nurses did. So when I was a medical student, I don't know how I stumbled upon creating an elective for myself where I hung out with a visiting nurse in the communities. Someone must have told me to do that, and it wasn't part of our mandatory curriculum. but I was absolutely hooked and amazed. You know, this nurse who was a palliative care, you would call them a hospice visiting nurse, you know, did the kind of work that you guys do. And we went from a fancy house, you know, in a really affluent area. A woman was in her bed with jazz music and a fluffy duvet and, you know, a white gown and, you know, a fireplace in her bedroom. And
Wow.
we then went to another part of town where it was in a more of a rural area, a little bit of a farming community, where a husband was taking care of his wife on a mattress. There were flies everywhere. And, you know, I remember saying to her, oh, we have to do something about this. Like, this is not acceptable. And, you know, she was explaining to me that, you know, a home is a home is a home. And that is not what, you know, is the deciding factor of who will pull this off at home and who won't. And sure
That's
enough,
so true.
yeah, I later learned that the woman with the jazz music ended up having to go to the hospital because her family, who were plentiful, just could not manage it. They were not coping. But the one elderly guy taking care of his wife on the mattress with the flies in the basically a barn died in her barn, which is where they lived. And so I just thought it was the most creative, off-roading, artistic, crazily interesting, if that's a word, place to work. And I just never wanted to work anywhere else. And I still feel that way. I love it. There's not a
I love
day
it.
that I don't learn something new. Every single patient, every home, every family throws us a challenge. And I just love it. And I'm amazed at what people do when they're not interfacing with the healthcare system. I'm amazed what they pull off at home. It's incredible.
Yeah, the resilience of folks that haven't had any other choice but to be resilient.
Yeah. They are their own OTs, PTs, dietitians, nurses, doctors, pharmacists, rec therapists. They're everything. And they're treated like nothing in every other healthcare system. Oh, thanks so much for driving your loved one to this appointment as a nice chauffeur.
Yeah.
Chauffeur. No,
Yeah.
no, I'm sorry. That is more than a chauffeur, I tell you. And
Yeah.
And I
Yes.
know when I leave a home that the plan has to have been hatched with the family, my care team, and it has to be negotiated from what is the standard in the hospital to what is acceptable and doable and realistic in this person's home. And that's very creative and exciting, right? So I don't know.
A MacGyver.
Yeah, the MacGyver.
We're the MacGyvers. Yeah. I mean, that's
Totally.
what I also loved about it. And I started in inpatient care, but we still had to be very ingenious with some of our things that we did for wounds. And, you know, because, you know, we see wounds in hospice that you can't even imagine. They're not in textbooks. You don't know what to do with them. And you got to MacGyver things.
Yeah.
But the other thing, too, about how, you know, you were saying when they go to the doctor, they're considered the chauffeur, right? Thanks for bringing them here without any consideration to what they've been doing at home, but also being dismissed when they say that something's wrong.
Yeah.
Right.
Absolutely.
And they're with that person all the time. And the doctor's like, well, look fine to me. You know, I've been here for 20 minutes and she looks fantastic. What are you talking about? You know, and it's another kind of thing that happens is when they're just dismissed and told, stop Googling, you know?
It's horrible. It's really, we really do not know how to truly incorporate families into, you know, the healthcare at all. or to incorporate us into their care. I mean, we have as tokens on patient advisory and family advisory committees and things like that. And they barely get a say in at those committees. But on an individual basis, we have really very little training on how to care for people as a unit of care, right? And what that really means.
Yes.
Unless you've worked in the home environment where you really have no choice. You walk in the door, you're on their turf. This is their home. And you are a guest, and there's no white coat. There's no, fancy language. We have to be real in people's homes. So yeah, I think that's made it easier for me to speak to the public because I've never been fanciful in the way that I talk. So I don't know.
Well, I think part of it too is, and why we're probably better at including the family in our provision of healthcare in hospice and palliative care, both there and here, is, well, I don't know what it's like there, but for us, we have interdisciplinary care. So our palliative care and our hospice is interdisciplinary care teams. And part of that care team is the patient and their family. They're considered a part of that interdisciplinary team. There aren't any other models of healthcare in the U.S. where there is an interdisciplinary team. It's your internist, it's your oncologist, it's your OBGYN, it's they don't collaborate, in normal healthcare. Yeah. But in palliative and so that's where I think the family gets to be more involved because we recognize them as a part of the team.
Yeah, I think we do also, again, in palliative care. But again, it's like too little too late. A person may have had their ALS for already, 4.5 years by the time you catch them. And so I love what we do. Don't get me wrong. We meaning that, the three of us and whoever else works in hospice or palliative care. But, we are providing this incredible service at the 11th hour after people have already become almost like on a conveyor belt of a factory. And just before they fall off the cliff, we catch them. I'm a little bit cynical today for some reason. I don't know why. I'm sorry. I'm not a real hoot today, but I just...
We're going to bring it back to hope because I do want to talk about the 8 seasons of your podcast.
Yeah.
Waiting Room Revolution, which is also appropriately named.
Yeah. Thank you.
And that's also with Dr. Xiao. So again, tell us a bit about how that came about. Or was it in conjunction with the book?
It was in conjunction. And we had Penny on as a guest, which was awesome. So the podcast started first, and neither of us had ever, even listened to a podcast, let alone tried to make a podcast. So it was very new for us and low budget, let's just say. And it was just a way to talk out what we were thinking with different guests and different stories. And we were able to elaborate on some of our thoughts. And then the book came afterwards. So really the podcast was just a way to, during COVID, to continue the work that we were thinking about. And, we have to try to be accessible to all different generations, right? So I'm of a certain generation, and there are generations who just lap up podcasts, and others who like social media, and others who want a physical book, and others who want, whatever. So this is a part of a social movement where we're trying to light a fire in the community, in the public, and create an absolute groundswell of people who are going to come to the healthcare system with a new mojo. And that, we're hoping, is going to force the system to have to say, okay, we can't really just be the same as we always have been. We need to respond to this new activated patient and family. So they're all these things are part of our social movement, which we're hoping at some point is less about CN and me and more, and it's already happening. We're getting signals now that other people in other countries are taking our work and running with it and adapting it. And yeah, it's great. We've had people from the UK and Australia and Tasmania and in the US doing different things, and asking permission. Can I just adapt that and change it a little bit for, this Indigenous group? Or, so those are really positive signs. And we have a workbook coming out because people who read our book said, do you have a course? Do you have a workbook? So we've just finished writing our workbook, and it'll be, I'll send you guys the advanced reading copy. It'll be out in November, but the actual workbook will be out in March, and it goes even deeper into sort of the practical skills to help a patient and family be in the know and feel like their own individual, unique person throughout their entire illness, and push against, in the most respectful way, becoming a cog in a wheel or a widget on a conveyor belt. And so hopefully when the three of us are meeting patients in the future, if our social movement goes well, we won't be spending so much time untangling them, and we can really spend the time doing what makes most sense with them, right? And what they want it to be.
I was just going to say, I mean, Dr. Sammy, just even from reading this and listening so far, it's already made me think of different ways to talk to my families as we're still in this space. And like you said, I'm hopeful that down the road, it won't be so much of that, and we can really spend time on focusing on that quality of life.
Yeah. Oh, that's really wonderful. I'm sure you're incredible at what you do, both of you.
Thank you.
This is the best part of going public is, meeting people. Like when we went on social media, I was shocked that all of this was happening behind my back. I couldn't believe it. And you guys are early adopters. Like I was so late to the game, and I still have no idea what I'm doing. Thank you for your tips, Penny. I have like no skill in this department. I just, whatever. But
don't worry, OG helped me too. OG. I was new at posting, so yes, she's very helpful.
I was so interested in your book, Penny, if I could mention that, when you said, way back when, before social media, you were, developing web pages and on the internet trying to like rally people together. I won't spoil your book, but like really, you are the OG, really the OG. Honestly.
Yeah, I always say to anybody who uses GoFundMe, you're welcome, because I was literally one of the first, what they called internet panhandlers, asking for money on the internet for a very good cause.
It's incredible.
Before GoFundMe was even around, and Facebook wasn't around. None of that was around. I was highly criticized for it. But yeah. And I think just kind of like with you and Dr. Xiao, like recognizing that there's a lot of strength in numbers socially, right?
Yeah.
Like
yes.
In our peer groups, that we can get a lot accomplished, probably more than politicians can, if we rally around, each other and try to
bolster each other up.
Movement.
Yeah. You know what? Honestly, I think I've been surprised, delightfully surprised by the support that everyone gives each other while we're doing this public facing stuff, because I think in the hospital and other care settings and amongst colleagues, it's not as supportive. And I just have been really touched by people's willingness to share what's working, what's not working, try this, don't try that. It's amazing. There's so much space for everyone.
Well, I think it's because those of us who do put ourselves out there on, on the interwebs, on social media, are really committed to advocacy. We're passionate. I mean, that's what got me. I didn't try to go on social media to become like TikTok famous. I mean, originally I just went on there to learn how to shuffle dance, as I said before. I didn't. I never did. But, I've always been a passionate advocate for hospice and great quality end-of-life care since I became a hospice nurse. And once I realized that the public wanted to know more, I was like, oh my God, I have this opportunity to bring my experience and my knowledge and my expertise to the public at a grassroots level. And how cool is that? So I think that's why we support each other so much, is we're kind of all in it for the same reason. It's not about like trying to become a star. It's really about the mission, like that we're really trying to change healthcare for the better for everyone.
Speaking about networking and advocacy, can we just talk about your BFF, Dr. Faith Banks, for a second?
Oh, did you have her on your? Yeah,
Blessed. Yeah.
We did.
Okay. So Faith, a palliative veterinarian, I guess. So
amazing.
I don't know if she told you, we're high school buddies, and we were
she told us.
in class together. And she always said she was going to be a vet, and she was sort of a sure thing. And I always said I was going to be a doctor, and I was a real long shot. I don't know if just to make you guys feel better in whatever way this does. But I was a high school dropout, to be honest with you. That's
really,
yeah. So I think this is the first time I've shared that on any podcast, but I think Penny, you made me feel more brave to talk about stuff that maybe is in the closet.
And you should, because, I've talked a lot about my past history with legal problems, going to jail, drug addiction, alcohol abuse, and not becoming a nurse until I was 40 years old. Yeah. So people are really inspired by that type of thing. You should be talking about that you were a high school dropout and you became a doctor. That's amazing.
Just kidding. Back to Dr. Faith Banks. Yeah. So she and I had drifted for a while, just because life takes you that way. And it wasn't until I went on Instagram, almost like so I moved out of the city that I grew up in, which was a little bit of a suffocating kind of community in a way, but anyway, disappeared for decades, probably because I wasn't so proud of dropping out, and that wasn't customary where I came from, and whatever, life went on. And decades later, so no one had heard or seen anything about me since I was about like 19. And then when I'm 50 or 52, reappear on Instagram. It was like a shocking.
As a doctor, no less.
Yeah, it was a sort of a shocking coming out in a way. And I reconnected with lots of people, including Faith. And then she became very interested in, and I was inspired by people like you guys. And then I guess I inspired her, and it's sort of like a domino effect, right? And yes. She's really cool, and she's got such a cool practice. Yeah.
Yeah, she does. She is cool. I like her a lot.
You're on to it, Dr. Sammy. I think we all inspire each other to continue this work, this advocacy, connecting to each other, networking. I mean, it's just growing and growing. I want to make sure we're honoring your time. We have just a few questions left. Our new season 2 question we're going to ask everyone is our coffin question.
Okay.
What would you like to have done with your body when you die?
Okay. Oh, that's a good one. Well,
I can't believe you have to think about this. How do you not know?
I know. Is that crazy?
No, that's the point. It's not crazy.
Okay. So
it's not crazy.
Okay. If I could have okay. So there was a time where I thought I was going to be a marine biologist, and I was a scuba instructor. Okay. That was in the high school dropout days. But anyway, so one idea I had was being, cremated and sprinkled in the ocean. But I don't know if you know this, I'm Jewish, and Jewish people don't usually get cremated. So I would have to be dismembered and thrown into the ocean. And I think that would not be good. So there goes that idea. And then, so I think I'll be buried whole. And I think that I will make sure that I'm not buried in anything fancy. So I don't want money spent on a fancy, like a pine box is fine. And my family can inscribe things on the box with maybe I'll have grandchildren at the time. They can color on my coffin and you know what? And plant me under a tree, maybe a nice big willow tree. And that's about it.
I love it.
I really don't worry about that part at all. I don't really worry about any of it, but I spend so much time thinking about dying that the dead part seems pretty straightforward to me.
I don't think that's unusual.
I'm sorry I don't have a better answer than that.
I think for a lot of us, it just doesn't matter. We're just like, oh, we're dead, do whatever. But I think who it's important for is who we leave behind.
Yes.
Exactly. Like they can decide what they can have, whatever. But
they're going to want to know, though. They're going to be like, what would she? Although I will say, I recently
or at least what you don't want. That's important.
Yeah. Well, I recently had a conversation with my sister, and I told her that I wanted to be body composted.
Oh.
And she said, well, it doesn't matter what you want because like she doesn't like it was clear to me that she thinks that's very off-putting. And she said, well, you're not going to be the one making the decision, so you can want whatever you want. And I was like, okay, well, so my husband will be making the decision. He knows what I want. Well, he might not go along with it either, she said. Well, he better. And then I said, and if he's not around anymore, you're my second.
Yeah.
So are you telling me I can't trust you to make decisions? Because for me, it's really not like I'm not concerned about what happens to me. I'm concerned about the environment because I have grandchildren.
Yeah.
And I don't want to be cremated. I don't want to have chemicals put in my body. I don't want to take up space in a funeral home. And so that's what it is all about for me. But I was just like, wait a minute, you are my second decision maker. So what are you telling me here?
You're going to have
it doesn't matter what you want.
You're going to have to beg Halley to be your appointed decision maker.
Oh, that's a good idea.
Yeah.
Well, it's a little tricky. We'll talk about that. Maybe another episode we can talk about how decision making works when you're alive versus when you're dead.
Oh,
yes,
right.
That's true. You're right.
Okay.
The decision maker after you die.
That's right.
Your DPOA.
Yeah.
Stops being your decision maker when you die.
Mm-hmm. It's a whole other episode.
Yes, it really is. Well, thank you for being here. Where can people find you in the world? We've talked a little bit about your book, but you let us know.
Is there anything else that we haven't covered that you want to talk about?
Yes.
Nope. I think you covered it all. I'm really so excited that both of you have read the book. We're hoping that people in the US think it's as helpful as people have in Canada. We tried to make it non-country specific. And so we're hearing from other countries that it is helpful. And I'm hearing from you guys that you enjoyed the book. So that's wonderful. No, I think that we're all part of the same broad movement. And I'm just so tickled pink to have met both of you and you now, Halley. And we're just part of one community now. And you can just find me by just Googling my name, I guess. Yeah.
Well, on TikTok, you're Dr. Sammy Winemaker.
Honestly, I haven't been posting on TikTok for over a year, but if you want to see some good old videos, I'm Dr. Sammy.
They are good.
Dr. Sammy Winemaker, or my Instagram is sammy.winemaker. Or our waiting room revolution is www.waitingroomrevolution.com. That's our website.
Wonderful.
Yeah.
We will put all of that in the show notes. We'll have the book, Hope for the Best, Plan for the Rest. There it is.
Thank you. Get ready for the workbook.
Thank you.
Thank you, guys.
I'm so excited for the workbook.
Yeah.
Yes.
Thank you.
I'm excited about the workbook.
Thank you so much.
Thank you.
Thank you, guys.
All right. That was mind-boggling. I knew we were going to have a great guest, but like so exceeded my expectations.
Right. Me too. Me too. And I've known Sammy for a couple of years through, TikTok and like I'm mutuals with her. We text back and forth. I was on her podcast, and it even exceeded my expectations because for one, she's so well spoken, but down to earth and hilarious.
Yeah. Very funny.
Yeah.
Very spicy today.
Yeah, spicy, but also like, and I know you'll agree with me on this, like the things that she was saying, it's like as if it came out of my own brain.
Yeah.
Like what she's saying. It's so fascinating to hear about what's happening in Canada with their palliative/hospice. That they have struggles too. At the end of the day, it's free, which is nice for them.
Yeah.
We don't have that. Well, Medicare, if you got Medicare, hospice is free-ish,
Yeah.
Ish. You still have to pay for it.
But that doesn't include care, like caregiving at all. So.
Oh, yeah. But it was interesting too to hear about the care centers and how really the equity, how inequitable they are, and true. Like the cancer patients do tend to get more notice, I think, and probably because a lot of them are young. But yeah, fascinating episode. That was really fun.
Yeah,
Love having her on.
So many times something comes up in the middle of a conversation, I'll just have to stuff it because, like, we do not have time to be here literally all day.
I know. We could be here for hours. Yeah. She'll have to be a return guest for sure. After she gets workbook, we should just do an episode just all about the workbook.
Yeah. I'm excited to see it.
Me too.
I'm so glad you told me about this book so I could get it. And the more I deep dive into it, flipping through, I haven't read it cover to cover quite yet. I flipped through a lot of it. And then listening to the podcast caught me up on a lot of what was already in the book. And I'm not just, that's not just lip service. I am going to be changing the way I approach conversations with people, even though we are at the end. Now we're having those conversations. Unfortunately, it should be upstream, but here we are. So
have you seen the table yet in the book? The table with the certain diseases and
no.
There's a table in there with diseases that has kind of like a expectation of what's going to unfold with the certain diseases.
Nice. Yeah. No, I'll check it out. I'm definitely bringing this to work, and I'm going to tell all my colleagues to listen in and check it out because it really is helpful.
It is. It's very helpful. It's really helpful. It empowers people to ask questions. And I mean, because we can tell people all day long, ask questions. When you go to the oncologist, ask them some questions. What do but I think when you're armed with more specific information and guidance, when you ask the questions, you're not going to be dismissed as easily because you sound more like you really want to know. Whereas you're like, doc, I really want to know, is this treatment going to work? It works most of the time. But if you have more information to be able to present, then they know you're serious and you really do want the answers.
For sure.
So, yeah. I
love it.
Great episode.
Another great one in the can.
Yeah, in the can.
All right. Until next time, remember to live.
Because someday we'll all be dead.